So this conduction system, you could talk a lot about the conduction system, but I want you just to understand that the AV node slows down conduction, right? We talked about that. So it comes from the SA node, gets the AV node, it slows it down. And that's important because of some of the arrhythmias that we're going to talk about. If the AV node didn't slow down the arrhythmias, you could get going very fast. You know, if you had like a flutter or atrial tach. If the AV node wasn't slowing down the flutter, your heart rate would be 300, right? And you'd pass out. So the AV node can be very useful in that it slows down conduction. After the AV node, you go through this, it's like a super highway, going down the right bundle really quickly to the right side. And the left bundle, which has anterior fascicle and posterior fascicle. Don't even worry about the fascicles. At this point, just know that there's a left and a right. And generally speaking, if you block one of them, the reason you get a wide complex, QRS complex, is because now it has to go from myocyte to myocyte to get to that side. It's not that it stops conduction altogether, it's just that it takes longer. So the conduction continues to go through the left side as it would have otherwise, but the right side, it now has to go from cell to cell, and it doesn't have this super highway to go on, right? And it's the same with the left. And we see those, we'll talk about what that looks like. But if you block the left, you can block one of the fascicles, or you could just block the left altogether. And it goes to the right how it should, and it's normal. But the left side has to go from cell to cell and takes longer, and so that stretches out the QRS complex and makes it more than 123 small boxes, right? So here's the left bundle branch block, and I thought it would be useful for you guys to see. You know, we talked about normally the septum's activated from left to right. If you block the left bundle, you get rid of that, and so now the sequence of activation extends, and you get a widened QRS, and the normal septal Q wave that you would have had in these lateral leads is gone, because you're not activating the septum from left to right anymore. You're going to activate it from right to left. So you lose that low Q wave if you're looking from this side of the heart. Direction of depolarization, the R waves and lateral leads. So basically this is saying, if you look at the lateral leads, which would be V5 and V6, and 1 in AVL, right? 1, the positive sticker is over here. AVL, the positive sticker is over here. V6 is here, V5 is here. So they're all lateral leads. And all of those in a left bundle would have a big R wave, and usually it'll have a notch in it, so like a bunny ear kind of thing. So that's what, if you're looking for a left bundle, those are the leads you look at, right? Left bundle, look for the left side of leads, look for a big R wave, and look for that notch. And that's how you know a left bundle branch block. And I know this can be often confusing, but we can look at a couple examples. Here's the left bundle branch block. Again, big R wave. There's a little bit of a glitch in it there, but it's not. It doesn't look like bunny ears, but overall it's a big R wave. And then over on V5 and V6, V6 there especially, you can see a big R wave. AVL, you see a big R wave. So this is left bundle. If it were right bundle, I would look at the right side of these, V1, V2, and I would expect those to have an RSR prime, like a bunny ear type of a thing. And so some of the causes, there's multiple causes. Somebody comes into the ER with a new left bundle branch block and chest pain, we're going to take them to the lab because it's a STEMI equivalent. But sometimes it happens where they come in with a left bundle. I was on this weekend and we had a patient, and she was comfortable, comes in with a new left bundle, but her previous EKG was 4 years old, so you don't know at what point she developed that left bundle, and it turned out in her to be rate related. And so sometimes what happens is, as the conduction goes down through the AV node and into that HIS-Purkinje system, the right bundle in her case was ready for the next impulse at a heart rate of 75. The left bundle wasn't ready yet, it was refractory. So those cells in the left bundle weren't prepared for the next beat, and so it blocked. And so that gave her a left bundle branch block. When you slowed her heart rate down to 60s, now it got rid of the left bundle. So basically the left bundle had some disease in it to the point where if the heart rate got up a little bit higher than 70s, it was blocked. All right, so that can happen. Other things that can affect that, you guys can see the list there. So we can look at a couple more examples. Again, if you see a wide complex, first of all, you want to make sure it's not a ventricular origin like VTAC, VFib, something like that. We'll see a lot of examples of that. But when you see that wide complex, you got a P wave before it, then you know the conduction went down the atria to the AV node, that's the P wave, right? From the start of the P wave to the start of the QRS represents that delay in the AV node. If it delays too much and gets beyond one big box, that's a first degree block, and we'll show some examples of that. Okay? When it gets down to the ventricle, so this is the ventricular activation. So if it's wide, that means it's not going through that superhighway and conducting quickly down the bundle branch block, or down the bundle branches, right? So in this case, you got to figure out, why is it wide? Which one of those bundle branches is blocked? And so you look to the left-sided leads. One, you know AVL is left-sided because it has an L in it, right? B5 and B6, you guys know those are left-sided because you put the stickers on and you know that you put them on the left side. So when you put the stickers on, think about what you're doing and what leads you're putting where, and I think it'll help you remember this. And so you're seeing there's R waves in B6, 1 in AVL, and so this would suggest a left bundle. Again, why is it not a right bundle? Because you don't have an RSR prime in B1, and so that's a left bundle. Other things that it could be a ventricular pace rhythm, so you'd be looking for pacemaker spikes just before the complexes. Usually we put pacemakers, generally speaking, in the right side, and so they'll activate the right side first, which will make it look like a left bundle branch block. Right? So often, if you have a pacemaker, the morphology might look similar to a left bundle branch block. Let you guys look at the next one. Same idea. Look at the left-sided leads. 1, AVL. First of all, you're just looking at the whole thing and saying this is wide. Why is it wide? You got 1, AVL, B6. They're wide and they're tall, and there's a little bit of a glitch in them. But overall, you're saying this is not a right bundle because there's no RSR prime there. These are tall R waves in the lateral leads, and so this is the left bundle branch block. Again, thinking about pacemakers, you're looking for pacemaker spikes. I don't see any, so I could say it is possible that you could have a pacemaker where you don't see the spikes. Most EKGs and the monitor, especially the monitors upstairs, they're augmented, and so the computer sees the spike and it accentuates it. And so when you guys see those big spikes in the monitors, that's more of the software doing it than it is the actual pacemaker doing that. So right bundle. There's a couple causes. Some similar causes. We're less concerned about acute MI with right bundle. That just is how it is. Right bundles are a little more benign as far as people that present with a new right bundle. It's usually related to that conduction disease and among other things. But from a ischemic heart disease standpoint, if you see a new right bundle, you're not likely to rush them to the cath lab unless if you think there are ST changes that might suggest that they have an acute MI, or obviously if they have troponin elevation or another reason to take them to the lab. And so a right bundle, now we're looking over here. See the left-sided leads. You see an R wave, right? But it's not a very wide R wave. There's no bunny ears in there in 1 and AVL. You're looking over in B5 and B6, you're not seeing huge R waves in B5 and B6, right? Those are lateral leads. But in B1, it's wide, right? So you have to explain why it's wide. If the conduction system was normal, it would go down fast and it would be narrow. So I'm going to say from this that there's a little bit of an R wave, but there's definitely a big R prime. Combined with that, we see these S waves in the lateral leads. What that means is the conduction from the right side is delayed, and if I'm looking from the lateral lead and the conduction on the right is delayed, that conduction would go away from that lateral lead, which is why it's negative in the B5 and B6. And so those are the two things you're really looking for when you're looking for a right bundle branch block. The RSR prime B1, and then these S waves in B5 and B6. I think overall for you guys, when you're looking at rhythm strips, when you're looking at EKGs, the first thing is look and see it's wide, and then to try to figure out from there why. When you figure out why, we'll get into some of that differential kind of stuff. But you're looking at, is it coming from the top but down, going through the normal conduction system, but that conduction system is diseased, or is it coming from the bottom up and it's a ventricular source, either pacemaker, artificial, or it's the patient's own VTAC or something along those lines. Same idea here. I see these terminal S waves. I don't see a big R that's wide with a little notch in it, so it's not a left bundle, right? It's wide. And I see R, S, R prime here. That suggests a right bundle. And again, the terminal S wave is out here. So this is a classic right bundle branch block. Sometimes you have a combination, and you would just call it a nonspecific conduction delay. So that's also possible. But most of the time, if they're going to have a conduction, if they're going to have a block, it'll be either left or right. It'll be pretty clear the majority of the time. There's one more. So same idea. So lateral leads, let's just go through it again for repetition. Right now, I think you guys are probably experts at picking up right bundles, but if we do like 100 more and then I throw one in, it's going to get you. So lateral leads, S waves, V1, RS, R prime. Got it? Everybody good? You got that in your brain?